So today, what I want to do is talk to you about some of the ins and outs of case management, in particular relating to malabsorption issues for one case and an SAH management issue for another case. And I want to let you know up front that the cases I've selected are not like perfect textbook cases. They are real life, messy cases where things happen. Various issues arise related to compliance or timing, and that's just kind of how it works. So these are not scrubbed. They're just kind of real life and give you an example of the kinds of things you have to think about as treatment goes along. So just starting with the concept of malabsorption. So Dr. Walsh talks about malabsorption as an issue for slender people, particularly under methylators, who tend to require higher doses of supplements compared to the average person. So these people are often slender. They'll eat well, but not gain weight. They might have digestive issues, sometimes a history of constipation, diarrhea, rapid gut transit time, or irritable bowel syndrome. They might have a history of a gut event like traveling, getting diarrhea or giardia from even camping, and never have been the same since in terms of their gut function. They might just have normal dysbiosis like candida, SIBO, or other kinds of general dysbiosis. Another thing that's quite big, especially I think with undermethylators, is chronic stress impacting digestion. Anxiety and stress elevates your sympathetic tone and decreases hydrochloric acid production in the stomach, and that results in much slower emptying time of the stomach, the development of burping as a symptom after meals because the food is sitting there and it starts to ferment. This is rare, but I also had a case of undiagnosed pernicious anemia where the patient had developed significant GI metaplasia, which is a side effect of chronic vitamin B12 deficiency, since the GI lining turns over every 7 days, I believe. B12 is required for cellular replication, and the cell quality just goes down and down and down till the GI is just hardly working. Now, that does reverse over time when they get, B12 injections. And another potential case or condition you might see is cannabinoid hyperemesis syndrome, which happens from cannabinoid toxicity, where people are vomiting on a daily basis. Again, uncommon, but I have had several cases of that. So you might notice in somebody's labs that they have multiple deficiencies showing up. So they might have really low zinc, really low copper, even low iron. And if you're doing a methylation profile, they'll show low methionine, even if they're eating quite a bit of meat. So that's kind of a sign of poor protein digestion. Also, if you do homocysteine and methylmalonic acid for B12 deficiency, it will show up deficient. And as I said, rarely intrinsic factor blocking antibody related to B12 deficiency can be positive. And I've had that twice, I'd say, in the last 5 years. So people tend to have treatment resistance. So you're treating them with what appear to be the right amounts of various supplements, but their levels just don't bounce back, even though they seem to be very compliant. And I found in general people to be pretty compliant about taking things, especially if they're not teenagers, because they're very motivated to feel better. And so they're not, typically messing around a whole lot. There are some exceptions, people with a lot of, ADD issues that have trouble organizing things, but Okay, another thing that you might consider if you suspect malabsorption is a complete stool analysis, which looks at the microbiome, it looks at the level of digestion of the food, and include a stool elastase test, which shows pancreatic insufficiency. So if not enough pancreatic enzymes are being released, that can also impair absorption. And you might do a SIBO breath test. So there's considerations. So, of course, we can increase the dose of supplements, which we often need to do. However, you want to look at, is the problem in the stomach and pancreas, or is it in the liver, or is it in the intestine? And there's different types of holistic treatments that you can use to support each of these. For example, I will often prescribe digestymes, which contain hydrochloric acid and pancreatic enzymes, with somebody with malabsorption for the first year or so of treatment. And that just helps everything digest better. It gets them with enough nutrients to be able to repair their systems, and often they don't need to continue with that later on. The other option is to support the liver, which could be a dandelion root tincture or decoction and liver detox formulas. There's a lot of those available. Now, if the intestine is the problem, getting into eating fermented foods, maybe taking a GI repair formula, which are combination prebiotic, probiotic, and minerals often. They often have fairly high doses of zinc in them. Probiotics are available. There's a few different ones available, and VSL or Visbiome are prescription ones that could be covered by their insurance potentially. And then prebiotics, meaning increasing the variety of vegetables that they're eating for fiber, taking inulin or prebiotic formulas. And then the other thing is oral IgG, which is usually derived from bovine serum or from colostrum, and that can really calm down a chronic inflammation that's set up by a previous infection. This is a 22-year-old female non-binary person who had a normal psychiatric history until 10 months previously when they had a total psychotic break and had to be hospitalized for a couple of months. The previous medical history of significance is that they had had Lyme disease about 4 years previous and developed some chronic joint symptoms, but they were mostly under control. Then, just about a month and a half before the psychotic break, they developed COVID and their Lyme symptoms went crazy. Because the Lyme symptoms were so painful, they started using cannabis heavily in order to medicate for the pain. At the same time, they were under quite a bit of family stress around their desire to transition and had started using testosterone. And all of these factors were like a perfect storm that blew into this psychotic break. There is a fairly significant family history of bipolar symptoms or bipolar disease, but I'm not 100% sure if that's really what's going on with this patient, since you'll see they just really never had another problem with it. But so they described having had the worst year ever. They were hospitalized for a couple of months, medicated to treat the psychosis. They're now not on any medication and are in therapy twice a week. They get sore throats regularly every week or so as they get tired, especially by the end of the week. They have a slender build. They have stretch marks, which is sort of surprising considering they're not overweight, they've never been pregnant, et cetera, et cetera. And they have nail spots, white spots on their fingernails. So I initially just went ahead and put them on some zinc and P5P and vitamin C after the first visit. And talked to them about the importance with bipolar of having a really regular schedule of sleep, sleep time and waking time, and also regular meals throughout the day, and not going and getting really hypoglycemic or anything like that. And so they implemented that, and they had also previously taken myo and chiroinositol, which is, I think it's called balanced B8, and that is known to be helpful for bipolar. So I said, just continue with that. And that was, then we tested their blood immediately before they started the zinc, and we got those results back in a little bit. So significant mental health history from a Walsh point of view is that at 1 year old, they had diarrhea and weight loss, and turned out that they had celiac disease, so they've eliminated gluten. At 5 years old, they developed hemolytic uremic syndrome due to an E. coli infection and ended up hospitalized in the ICU and on dialysis and had multiple transfusions. After that, they had several years of delayed growth and a lot of anger. So then as they started growing more, they developed chemical sensitivities, which their mother also has. And also the chronic Lyme disease was diagnosed at 18, and the COVID triggered the psychotic break at 21. And they've also had 2 concussions. So, psychiatric meds, really not anything except for the antipsychotics at the time of the hospitalization. And behavioral stuff, they admitted to having temper tantrums and basically screaming matches, but primarily just with their family, not with other people. Some OCD tendencies and a general feeling of being inadequate or unworthiness. Now, the lab values that came in were very surprising to me. I mean, not in retrospect looking at their history, but they had the lowest zinc I have ever had in a result for a patient, which was 46. That got my attention immediately. Their copper was 83, which is fine. Their ceruloplasmin was 22, which is just about perfect. Ceruloplasmin should be about 25% of copper. And their free copper was fine. Their copper zinc, their free copper index was fine. And their copper zinc ratio was way off simply because the zinc was so low, not because the copper was high. So in the calculator, if you're a Walsh trained doctor and you know about Dr. Sickles' calculator, it said that the zinc dose to reach 100 was 5,128 milligrams a day. So that gave me full permission to give, several hundred milligrams of zinc as a dose. Other tests were pretty normal. So we started the treatment plan. I put them on 200 milligrams of zinc picolinate, some P5P, and vitamin C 4 times a day, and that was primarily for their immune system. And we continued on the balanced B8 and implementing the routine. So we just kind of started there, and part of the reason for that is this is a college student who's less, has a harder time managing taking a lot of pills. So I was trying to pare it down to the absolutely what was essential. Now, a little bit later, we got back their cryptopyrrole analysis, and their, cryptopyrrole level was high. It was 21.77, not crazy high. And I would expect it to be high with the zinc that low. In fact, I would have expected it to be higher than that. But right now, you can't tell, is this a genetic cryptopyrrole problem, or is this related to the zinc deficiency? Or are they connected in some, is there a genetic connection to the zinc deficiency with the cryptopyrrole? So that's something we'll kind of figure out over time. Now, at 3 months, their zinc level had come up really solidly, and their copper level had gone down a bit. So we don't want the copper going down too much. And what we did is pulled down the zinc level a little bit to see, to see how that moderates. However, what happened was, so this is at 3 months, and then we did a repeat of at 4 months, and the zinc had gone way down, so down to 68. And then at 5 months, it went down to 50. So that was, not good, obviously. So let's see. We did a follow-up, and it turned out that just around the time when, just before they had had the last blood draw, they had been camping in Arizona and had gotten exposed to river water and developed diarrhea, which was quite severe. I had ordered a stool test, but they had not gotten that done. And so I presumed something was going on, like giardia. And so I had them stay on the vitamin C and the Pyrrole AM, which we had started after the Pyrrole test came back, and increase the zinc and copper dosages. So I had given them 1 milligram of copper per 50 milligrams of zinc. Now, I also started them on Designs for Health Digestymes, which can contain both hydrochloric acid and pancreatic enzymes, along with some ox bile as well. And I also prescribed Paragard by ITI, which is a herbal combination for giardia, and it works very effectively for a variety of different problems, actually. So that worked really well for them. I didn't see them for quite a while. They were doing really well. And then, of course, summertime, getting a job somewhere, they lapsed on their supplements a bit, but we're trying to be consistent with the zinc. Their next lab test was, the zinc level was pretty good, but their copper was still pretty low. And everything else looked pretty good. And their KP had come down significantly, was still a little bit high. So then they said, oh, well, I haven't been taking the Pyrrole AM for the last couple of months. So then we get them back on the Pyrrole AM and increase the copper a little bit more as well. So at that time, we also drew a methylation profile because their family members wanted to know, if they were undermethylated or whatever was going on. So now this methylation profile does not look too bad to me. The SAMI's a little bit low. The methionine's, I really can't say it's low. It's still in the green zone. But it's telling me, they may not be absorbing that much methionine because of malabsorption in general, and they do have a fairly heavy meat diet. So, but to me, this is not significant undermethylation, and their homocysteine level was fine. So that just seems okay. So this I didn't really pursue very much with them. And interestingly, though, the parent who wanted to have this done is undermethylated. And I have seen that a lot, that parents who are undermethylated become very wanting to get every possible test for their kids. Okay, so at 15 months, again, they got COVID. And they had been traveling in Mexico. They had had a real serious corn allergy developed and were exhausted from travel. Their digestive symptoms had gotten a bit worse, and their anxiety and depression symptoms had started to come, not all the time, but sort of in waves. At that point, we just, maintained taking the zinc. Travel had disrupted their compliance quite a bit, and so we got them back on the zinc and the enzymes. They weren't able to get any labs drawn at that point, but we got them back on the cryptopyrrole again. So what happens is, people kind of, especially in this age group, so teenagers into college, there can be a lot of things going on that interfere with regularity of taking supplements. So then at 17 months, we got another lab test done, and their zinc now was at 82. Their copper was, the 46 is their very, very original zinc level. And their copper was back up to 81, which was similar to their original copper level. And ceruloplasmin, which let's just say CP instead of CU down there, the ceruloplasmin should be 18. Okay, not 81. Um, so, and I changed them to, because compliance was such an issue, I found a product from Amen Clinic that's zinc, copper, and a probiotic combination. And so I decided to try that to reduce the number of pills that they needed. And they had started doing EMDR with their therapists, which they were finding really helpful. Okay, so we had some interfering factors with their zinc level. At the very beginning, it was very low. Um, we got them on zinc, it came up, and then we adjusted the dose a little bit, thinking, well, okay, they don't need quite as much, but then it just dived again. And this is really something that you see in people who are um, have malabsorption issues, because things can change depending on what they're eating. If they're eating foods they're allergic to or sensitive to, it can change, or they can get a little stomach thing going on and it can change. So it really plummeted. Then they got Giardia at number 2 and it went way down again. And then we got it back up into the 105, which is really our target area. And then they got COVID and another digestive problem from travel, and it went down again. So this is the type of thing you're going to tend to see in people, especially, with COVID or the flu. With any other kind of big infection, I've seen this problem with chronic infection, for example, like hidradenitis suppurativa. You have to just give people a lot more zinc to keep them at a decent level. So, okay. The Pyrrole AM, they had developed some problems with in terms of nausea. So we had them move it from breakfast because they didn't eat much of a breakfast and they were taking it on a very light meal. So I had them take it at lunchtime with the first really full meal of the day. But if they didn't tolerate it, I had them gave them a separate prescription that they could switch to vitamin B6 and biotin taken separately, and lowering the dose of B6, which frequently can cause nausea. So in this case, there is a need, especially I think with this age group, for continuous monitoring, supporting them to, stay focused with their supplements and all of that. The main thing that's interesting, though, is once their zinc level got up, even when it was at 60, they were not having a lot of mental health problems. They had a bit of anxiety and, depression coming here and there, but it was nothing compared to what it had been before. And so, they have never since had any kind of elevated states or bipolar type states or any kind of psychotic break since being in the treatment plan. The main thing is figuring out how to help them manage the dosing as best possible. So that's just how it can be kind of messy instead of all neat and tidy like we would prefer it to be. And it can take a lot longer to get to where you really want to go, depending on life events that occur, like travel, illness, and other kinds of stresses. Okay, so let's move on to the next case, which is a 62-year-old female who has a history of breast cancer and ovarian cancer. She's been treated with SSRIs in the past, but did not feel she responded well to them and didn't like them and took herself off of them. And she recently became quite depressed and got onto another medication, which is bupropion. And she has been feeling a bit better since she started taking that. But she desperately wants a drug-free approach. She's very naturally oriented and does not like medication of any kind. She has had depression on and off during her life and has a family history of dementia and ADHD. Other elements are that she has kind of chemical and sensory sensitivity. She uses a CPAP for sleep apnea. And in our discussion, I discovered she never cleaned the tubes or replaced the tubes. She didn't know they were supposed to be cleaned. So I got her doing that right away because people can actually develop mold sensitivities, which the chemical sensitivity could be related to from mold developing in the CPAP tubes. She has a history of concussion and rage, and she's a longtime vegetarian. Her DAS-21 score, which I had her do based on her symptoms prior to taking the bupropion, were depression. Her depression score was 36, which is extremely severe. Her anxiety level is mild, and her stress level is moderate. So this is a 21 question survey that tries to differentiate between these three elements because patients often can't fully differentiate between them, especially with stress and anxiety. Okay, so now this is a form that I use in my practice that I just made myself. And it breaks down the different symptoms in from a Walsh point of view into categories. So the left category is mood and thinking, then behaviors, then drugs, symptoms, and signs and traits. And so I'll often just mark it up as I'm talking to the patient, asking them questions, and I kind of try to go through all of these elements. So in this case, they had a variety of undermethylation symptoms, including chronic depression, perfectionism, rumination, a bit of oppositional defiance, strong-willed, family history of accomplishment, and pain tolerance. But they also had a lot of overmethylation symptoms, like high anxiety, again, depression. This is a person who is very religious compared to my normal patients. That got my attention. Low libido, artistic and musical, a lot of pacing, nervous legs, dry eyes, dry mouth, sleep disorder, bit hairy type body composition, and gets a lot worse on estrogen. I also looked at the copper overload symptoms. They had a few that seemed to possibly relate to copper overload, but very few that really tied into pyroluria. They had been taking some zinc already and eat pumpkin seeds in their diet. Okay. So we did some labs, and turns out they had pretty decent zinc level, and especially for a vegetarian. And copper was a little elevated, but not terrible. It did give them a bit of a high copper zinc ratio and a little bit high free copper at 120, or the copper zinc ratio at 126. I'd like to see that down to 1, especially if they are depressed. And they had one copy of A1298C MTHFR gene, which the lab says has no impact on homocysteine, but I have seen it have a mild impact on homocysteine. So I started them on treatment. Oh, sorry, let's go down to the methylation profile. So this chart is from Doctor's Data Methylation Profile, and it shows that they have reasonable levels of methionine considering they're a vegetarian, and there are not a lot of good sources of methionine in vegetables and nuts and things like that. There's some. Pumpkin seeds, I think, also have that. Their cysteine was okay. Their SAMe was like totally perfect mid-range, but their SAH was really elevated. So this is interesting because it kind of explains why they have some undermethylation symptoms, but they also have a lot of overmethylation symptoms, and we're not really sure what's going on. SAH elevation is extremely undermethylating. And they appear to be normally methylated, but when I see this and I know they're a vegetarian and their methionines like a little bit to the left, I'm kind of thinking, if we get this really working, it's possible their SAMe is going to come up. And we've got to really watch for that because we don't want to push the SAH up any higher. So, and notice their homocysteine's a little bit edging up, and it's only 8.5, but we like it to be 5 or under, really. So now I started basically treatment with, I wanted to increase their zinc a bit more and bring copper down. Their vitamin D was a little bit low. It's at 33. I wanted to bring that up, especially since they were, depressed. And I put them on niacin, which is nicotinamide riboside, and D-ribose to help bring down their SAH. Now, again, this is a thing of I don't want to take that many pills, so I'm trying to pick out, which pills I think are the most critical for them to start with, and then maybe we can add some more in later. Okay, so a 2-month follow-up, they're in a much better mood. They have self-weaned from bupropion. They're not all the way down yet, but even though I said, please do not wean yourself off bupropion because you are really depressed and we don't want things to get even worse. They just were not willing to wait. So they had been weaning themselves down. And they have been doing more spiritual things, which was really helping with the depression. They're being treated really for relative copper overload, which is really just mild, and the high SAH. So I decided to put them on homocysteine plus, which is a formula that has some serine in it. It has a little bit of MTHF, methylfolate, a bit of B12, and it has TMG, all of which are helpful for SAH and bringing the homocysteine even lower. So if we start moving the SAH, it's going to move in around the circle. It's going to start hitting that homocysteine. I just didn't want it to back up. Oops. Okay, I started them on zinc primer, which just was a more efficient way to get them some other B vitamins and things. They were on the niacin and the ribose powder. They continued on that. They had a lot of improvement I had been seeing them for other issues like osteoporosis and kind of monitoring as we were going along, but we did a final 11-month follow-up visit on just their mental health status. And they were really happy, feeling really great, the best they'd felt in years, and had been completely off the bupropion since month 5. But they very recently had a resurgence of depression and anxiety. So I tested their zinc, it was 95, and we redid their methylation profile. And if you see what's going on, their methionine has gone up a lot, their SAMe level went way up, and their SAH is even higher. So no wondering they're not feeling as good, but still feeling way better than they were when they first came in. Now, I suspect the methionine has improved because they're on a bit more zinc and that helps. Zinc is required for hydrochloric acid production, and that really helps with protein digestion. Okay, so what's happening right now is that she's showing up with overmethylation in terms of an elevated SAMe level, and that does match her initial symptoms. So I decided to go ahead and start to treat her overmethylation. I believe that was connected to the increase in anxiety. So I started her on folic acid. She's kind of a small, petite person, so I went with a slightly lower dose, which was 800 micrograms twice a day, instead of 1 in the morning and 2 in the evening. And B12, also 1,000 micrograms. I started her on DMAE. She continued with the niacin and the serine. And then we continued with the SAH treatment, so the serine and ribose and niacin also help with SAH. So that's that was very helpful for her. And we did a follow-up a couple months later, and she was doing really well. She said she had a very high stress period prior to the visit in which she had had an episode of identity theft and had spent hours and hours dealing with, all the different issues that you have to deal with identity theft. You have to change all your passwords. You have to, get your ID replaced and all kinds of things. And additionally, she had a close friend who has a terminal illness, and that was very upsetting and stressful to her. But overall, she felt very mentally robust. And we did another DAS-21, and that showed a dramatic improvement from her baseline. So this is the DAS-21 scores, and her depression score at baseline was on the far left, 36. It went down to 8, which is nothing, normal. The anxiety score stayed about the same, and the stress score went from pretty high stress down to lower, again, down to below the threshold for mild stress, to what's considered normal. So there was a big improvement in her symptoms that was reflected in her DAS score, and she's doing really well. And she loves the approach. And so she's gotten better about, she knows she has to take all the different things. And one of the ways that I handle ribose to make it a little easier for people is it comes as pills, but also comes as powder, which is mildly sweet and no other flavor to it. So I just have them put that in their tea. So it's not like they're taking a pill. They're just, putting a little sweetness, very mild sweetness into their tea twice a day. And that helps a little bit with the compliance. Okay, so with SAH, what I have found is that it's really worth testing, ordering a methylation profile if the patient is benefited from bupropion more than other drugs. I've had this with numerous patients at this point, and I don't know exactly how it all works, but it does seem to help. And with other patients, I've even seen their SAH go down when they're on bupropion. Also, if you notice mixed methylation traits, if you notice quite a few mixed methylation traits, meaning they have some over-methylation traits and some under-methylation traits, more than just a few, it could be that they're actually over-methylated but have high SAH. And again, I've had this pattern in several patients, and even people who are extraordinarily over-methylated, but also had extraordinarily high SAH. And that's, really needs to be addressed. Then the other time I've noticed this where I've ordered a methylation profile is when you're treating somebody for under-methylation, and they have an initial improvement for a few months, and then they start getting really depressed. And what I've seen happen is you bring the SAMe levels up with the treatment, but because they have a fault in, like a SNP in how their SAH-H operates, the enzyme to convert SAH into homocysteine, it's not working properly. So as soon as their SAMe level comes up, their SAH just starts to pile up in that step, and that makes them feel very depressed. So I think that can be an issue. And the other thing that I've seen happen is when people get their digestion treated, like say they have SIBO or dysbiosis or IBS, and you're treating that to improve things, and their digestion's getting better, and then their mental health symptoms get worse. I think that can also be, I've seen that happen where the SAH starts to go up. It doesn't always reveal itself in the first test that you run, because if they're undermethylated or they're not digesting, they're not really showing, where, like, that SAH doesn't have a chance to really show up. So it can come on later on. So One of the things that I've seen, and as a naturopathic doctor in particular, I'm looking at a lot of different things going on with the person, but it is so important to deal with their digestive capacity and really look at what's going on if there's any hint that there's a problem with digestion. Because any different type of problem can impact absorption or it can impact digestion or breakdown of foods and nutrients. So this will have or can has the potential to have a really profound influence on their situation. And the other thing to think about with patients is that in general, overmethylators will tend to benefit more from a vegetarian diet because they're really good at producing SAMe. They tend to absorb methionine pretty well and they tend to produce SAMe really well. And most of the methionine in the diet is coming from meat. So they don't need a lot of it. They don't need a lot of meat in their diet to still have a proper level of methionine and SAMe. However, undermethylators, so they do well as vegetarians. Undermethylators do not do well as vegetarians because they're not good at producing SAMe, and they need a constant source of methionine, which is more easily available through meat or fish or whatever animal products than from vegetables. And yet you often find people who are really undermethylated and are vegan or vegetarian and are very married to that diet. So that is something to think about as well, because that will influence their lab results and make it confusing, or make them appear even more undermethylated if they're not eating meat. And like I said with the overmethylators, it's the opposite. So those are, and I talk to people about that because not every diet's perfect for every person, and this is a really good example of that. So I hope you've enjoyed this little foray through a couple of real life cases showing different types of things developing, different patterns and different compliance issues that can arise. And I hope that you have this helps you in managing your own cases.
Hey, you guys, that was Dr. Seroya Crouch, who is with us right now. She is about to start taking live questions. Everybody, please give Dr. Seroya Crouch a round of applause. Clap, 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 clap. I know you're all clapping at your desks. You guys, here she is. I'm going to be introducing her shortly here. Dr. Crouch is a licensed naturopathic physician with nearly 4 decades of experience in integrative and energy medicine. She has held leadership roles at the National University of Natural Medicine and Endeavor College of Natural Health, and co-developed the first interprofessional fellowship in integrative health and medicine with AIHM. Dr. Crouch is formally trained in the Walsh Protocol for mental health and applies this biochemical approach to clinical practice, using nutrient therapy to support patients with anxiety, depression, and behavioral disorders. Her work integrates evidence-based functional testing, energy psychology, nutritional counseling, and botanical medicine. She practices in Vermont. Welcome, Seroya.
Hi there.
Hi, just making sure. Okay, we can hear you good. You guys let us know that you can hear us okay in the chat, and we are going to get going with our live Q&A portion. We had a ton of really great questions about biomarkers and the chemistry that is foundational here in these malabsorption patients, commenting regarding potential deficiencies to look for with malabsorption. Is it common for both zinc and copper to be low at the same time? I'm used to it being on the low end and the other on the high end.
So that's a great question. There's a couple different reasons zinc and copper can be low together. So one is it's not uncommon for people who are undermethylated to have a fairly low copper in the 80s, 70s, that sort of level. So that that can be true. And if they also have low zinc and you're supplementing them on zinc, you have to track that, because if it drives the copper down lower, that won't be good for them, because copper is required for a lot of different functions. So you might have to supplement a little bit of copper, and usually we do about 1 to 2 milligrams per 50 milligrams of zinc. Okay, and there's formulas that have that basis that are pre-made, or you can just get individual copper supplements as well. Sorry, I think I might have forgotten part of the question. Oh yes, so the other reason to have it is, in malabsorption, people are just like not good at absorbing things in general. And so I've seen, like I've said, iron can be really low as well. So they're just not really, minerals aren't always the easiest thing for us to absorb. And so if digestion isn't working well, you might see kind of a mineral deficiency across the board, possibly also magnesium. And that might show up as, muscle cramps or headaches or things like that, that are relieved when you take magnesium.
Mhm. Thanks, Dr. Crouch. If copper and or ceruloplasmin are low, can that cause iron to go high?
I don't know about that. I don't think it can, but I'm not entirely sure. Like in somebody who had, for example, hemochromatosis, I don't know if there is a relationship between copper and ceruloplasmin and iron in that case.
Mhm.
So I can't really comment on that, unfortunately.
That's fair. When you're looking at copper, how often are you looking at percentage of free copper?
Oh, every time. So when I'm testing the copper, the percentage of free copper is a calculation. And so anybody who's trained in the Walsh approach, we learn about that in the training, and there is an online calculator we can plug our results into, and it calculates free copper and free copper index, as well as the copper zinc ratio. And the free copper and free copper index calculations are more complex. I can't tell you what they are offhand. But they're kind of an idea of how much rock, like unbound copper circulating in the system, causing irritation and oxidative stress. And then the copper zinc ratio is just a straight ratio between the two, which also kind of shows you it tracks really well with symptoms. Let's put it that way, if you have a high copper zinc ratio.
Mhm. I'm glad you mentioned the ratio of copper to zinc because we had a couple questions come in there. It seems like most practitioners are looking for the ratio of copper to zinc to be 1-to-1, and I'm wondering if that's the case for you and what Dr. Walsh is recommending to his trainees. I know you've been through the Walsh training, and I know a lot of our providers are looking at it or even been through it themselves.
Sure. Well, Dr. Walsh recommends it be that the ideal range is between 0.8 to 1.0. So, I like to get it to 1, but I like to push it a little bit lower if we can, because, with some patients, even getting up to 1.2 will be symptomatic for them. And that's not, from 1 to 1.2 is not that big of a leap. So if you can get them down to 0.8 or 0.9, it gives you a bit more leeway.
Good answer. Let's see. What are the top signs and symptoms that you'd consider running the various cryptopyrrole tests?
Okay, well,
This is a loaded question.
yes, I can tell. I only run one cryptopyrrole test, which is the DHA test, and I do that basically on the basis, initially, I would say, of Dr. Walsh's recommendation, but also because that test has been corrected for specific gravity automatically, whereas not all other tests that you run are. And there's a lot of care and attention to the directions for preparation of the sample, shipping of the sample, getting the sample tested immediately so it doesn't, denature before it actually gets tested. So, I feel really good about that. And there's very good service with DHEA as well for the customers and everything for the patients and for the doctors. So that's the lab I use. And I can, there are a bunch of different symptoms that you learn about, symptom profiles that you learn about in the Walsh training regarding the different biotypes. And so the pyrrole biotype is really has to do with poor stress control. There's a bunch of different symptoms, but poor stress control, like they blow up, they can't handle stressful situations, they're sobbing, they're kind of going all over the place. They could have very severe anxiety and severe depression. Often they don't have very many dreams that they remember, partly because their B6 is very low generally. They often tend to skip breakfast and really like, spicy and salty foods, also because their zinc levels are low and their taste buds aren't working all that well. So they kind of need that higher level of flavor to be able to really taste things well. Irritable. Things like other types of skin symptoms that are related to zinc deficiency, such as stretch marks. So for example, that first patient that I mentioned was 22, not overweight, never been pregnant, but still had stretch marks because the skin itself is not elastic enough that as they're growing, it's able to grow with them properly. It literally sort of tears. So also there's a characteristic of sort of delicate facial features. And I have seen this where like, I kind of see somebody and I kind of go, oh, they might be a pyrrole person. I should definitely test that just because of the way their face is constructed essentially. And their skin tone and things like that. So often they don't tan, they just burn. But I think the big thing with pyrrole is this, the stress issue where they're just really don't have emotional regulation. And this can happen either because they're born that way, they have a pyrrole genetic condition, or because they have been under a lot of stress and have been pushed into a cryptopyrrole state because the stress has drained so much of their B6 and zinc that they're ending up producing too many pyrroles. So I think I covered everything there.
That was really great, you guys. I posted in the chat the link to our past webinars because I could sit here and list 20 more symptoms of pyrrole disorder because, it's extensive and not everyone with pyrrole disorder is going to present the same. So it really takes a close eye, it takes training. And there are some things that are super common, and check out our past webinars. We have 2 that talk about specific pyrroles, and they're actually both by Dr. Susan Delaney. She did one on ADHD and one on addiction, and she covers a lot of the symptoms in detail there. So I think that would be really helpful. The second part of that question was, are these tests from different labs equal in quality, or for one reason or another, does one or two stand out among the rest? So Dr. Seroya Crouch answered that a little bit. She said it was Dr. Walsh's recommendation to use DHA's lab cryptopyrrole test because it's the most reliable and accurate test. The reason why he is recommending that to his students is because he did studies where he ran 3 cryptopyrrole tests on the same patient from DHA, which is us, and a couple of different labs that were running the cryptopyrrole, and he was getting back different results from the same patient on the same urine sample from other laboratories, and ours were all reliable and consistent. And I'm going to tell you why. I can drop a whole slide deck on it. I'm not even on our sales team, so please, Seroya, if I'm missing anything, let me know. But a big thing for us is that we have the strictest requirements and protocols that we recommend and require for the transport of the cryptopyrrole specimen because it's unstable and because it degrades easily and because we need to maintain the integrity of such a sample. Our samples are never refrozen when they get to the lab. We have really strict shipping requirements. You're only allowed to ship them Monday, Tuesday, Wednesday. If you're doing international orders, we require dry ice, so it gets through customs and gets to us at a temperature that keeps the specimen stable. We do the specimen 5 days a week, Monday through Friday in the lab, okay? So your sample is never put back into the freezer. And there's several other stuff, like we use different types of preservatives. We use vitamin C ascorbic acid instead of different other types of preservatives, which can change the content of the cryptopyrrole. I could go on, but just please believe Dr. Walsh because he's the biochemist. Okay, I am not, and the researcher, and Dr. Seroya Crouch. So that just briefly explains that. And speaking of pyrrole, somebody asked, Dr. Crouch, what is pyrrole AM?
Oh, that's a great question. Sorry, I kind of, was thinking everybody has taken the Walsh training already on this webinar, but I'm sure that's not the case now that I realize it. So there is a company, so Pyrrole AM is a formula that Dr. Walsh developed or specifically for treating pyrroles. So there is a company called BrainscienceNutrition.com, and they produce some formulas that Dr. Walsh has created that are sort of close to doing like compounding pharmacy formulas. So for example, with the Pyrrole AM formula, it has everything but the zinc in it. And it's got lots of P5P and B12. It's got like 300 milligrams total P5P and B12. It has some vitamin C. It has a bit of magnesium. It has ALA. It has biotin. It's got a few different things that are related to the processing of the pyrrole, but the zinc is not included because the zinc need for each patient is so individual. So you could do with a typical pyrrole patient, you could do the Pyrrole AM plus just a zinc supplement in addition. Now, they also have other things that I mentioned in the presentation, like zinc primer. And zinc primer is a formula that has comes in two sizes, 25 milligrams and 50 milligrams, and it has B6 and P5P in it. And I can't recall everything else. I think maybe one or two other things in it. Again, formulated by Dr. Walsh to help people deal with things, but I do not recommend in a case of pyrroles to use zinc primer plus Pyrrole AM because the dosage of B6 is way too high and people will be nauseous and not feel well and stuff. So we generally don't use those in combination. I use a plain old zinc, meaning zinc picolinate, because it's the most absorbable one for people. So yeah, but Brain Science Nutrition has some interesting formulas in there. They also have the metallothioneine formula that Dr. Walsh developed. I didn't talk about it here, but that's really for it has a number of different applications, but it's a great formula too. So they're a good company. It might look like their products are a bit expensive because one bottle's $50, and but for their 90 pills and for Pyrrole AM, one bottle lasts for 3 months. So it's a really good deal for patients, and it really cuts down the number of pills people have to take, which is, I have a big goal around cutting down the number of pills people have to take because that's what burns people out the most over time on these protocols. So if you can get it down to 1 or 2 pills a day, it's really great. But you can't always do that, so.
What happens if your client has histamine intolerance or mast cell activation that can be impacted by your suggestions and fat malabsorption as identified in the OAT test?
Okay, so those are kind of two different parts. So regarding histamine intolerance or mast cell activation, you have to really treat every patient individually. So if there are specific products that you think they're going to react to, like, well, it could be anything depending on the person, but you have to really treat the histamine and the mast cell problem. And the histamine can actually really, if the person has a histamine intolerance and you want to treat them from this mental health side of things, you probably need to do a methylation profile test. I recommend Doctor's Data methylation profile. Now you have to make sure you get the right one. They have 2 tests with methylation in the name. One is a DNA methylation That's a DNA genetic test looking at the genes pertaining to methylation. I've never run it. It's not that relevant. I have one patient I'm thinking about running it on. But the methylation profile looks at functionally what is going on methylation-wise, because in somebody with mast cell activation or histamine, high histamine levels, that is going to overwhelm the normal panel that we do, which is copper, zinc, ceruloplasmin, and whole blood histamine. So the whole blood histamine will be high, but it doesn't necessarily mean the person's undermethylated, that's a marker for undermethylation. There can be other causes of the high histamine. So it's tricky with that, those conditions. And, for example, I have a patient who had really bad, is super undermethylated. We've been trying to get her on SAMe for years. And, but she has, she had SIBO, then she developed RA, and she developed sulfur intolerance from hydrogen sulfide SIBO, and she just could never take SAMe. So we've had to delay starting that kind of treatment with her for 4 years, and it sucks. That's a medical term, by the way. It's really frustrating with certain patients. You've got to at least treat, you've got to figure out what's the order of treatment for that patient, and so it's going to vary, but sometimes you have to.
Sure. And I'm sure that comes with time and reps as a practitioner, and everyone's bio-individualized too. So you guys are up for it. I'm glad I'm not in the trenches like all of you. In cases of anorexia or other eating disorders where there's a real malnourishment component, how can we as holistic practitioners more effectively help their absorption and essence to build up? Anything they can physically eat or take, also things to say or avoid saying to provide the best possible compliance and all of that stuff.
Sure. That's a complex question, and I'm not a specialist that deals with, eating disorders and anorexia in particular. I have had a case of a boy with diagnosed autism who had an incredibly restricted diet and would only eat 5 foods, most of which had folic acid in them. Lovely, that made out of white enriched flour.
Yeah.
But what I was able to do is get him on zinc. And after being on some zinc for a while, and how they did it is they used zinc orotate and opened the capsules and put it in water. And all he would drink was water. He wouldn't drink anything else except water. So he couldn't taste the zinc in the water. So they would just give it to him and he wouldn't even know, and he drank it fine. And so after about, I'd say 3 or 4 weeks on the zinc, he started expanding his diet a little bit, eating, some yogurt, which was amazing because at least he got some protein. So, sometimes what can happen is if you can get like a little door, a foot in the door with some zinc, it can decrease some of the intense, I think deficiency / control issues that can happen. It can start to relax things a little bit. But, anorexia is like, it's a very serious life-threatening condition. And, you have to be, I think, I would say you need to take some special training around eating disorders to really treat it properly. So like I said, I'm not an expert. And I know that Dr. Walsh has mentioned in our training that he had treated some people with anorexia where, at least if they could take some of the supplements, they did start to improve on the anorexia scale as well. But you can't always get people with anorexia to take supplements either. So
Yeah, gosh, sounds just like a tough one.
Yes.
Another question about zinc and supplementation. I found that supplementing B12, B12 alone caused my zinc level to increase. Is this your experience as well? Absorption of zinc improved with B2. Who asked that question? Are you talking about B12 or B2?
Yeah.
Did I read that wrong? You think it's B2 or B12? Joy, can you comment in the chat? She said B2. I found that supplementing B2 alone caused my zinc level to increase. Have you ever seen that in
I
practice?
have not seen that. No.
Interesting. Maybe, Joy, maybe you're onto something.
Yeah.
You mentioned proper protein digestion during your presentation. What do you consider the proper amount of daily grams of protein to be eaten by women? For menstruating women, for non-menstruating women, does it change?
Yeah. Well, it depends on weight. It depends on body type. You should be feeding the muscle mass. So you need to really look at what is the muscle mass of that person versus their total body size. And I can't really say off the top how many grams of protein, but there are lots of guidelines around that. If you can do a bioimpedance analysis and get a sense of what their muscle mass is, or just looking at their body type, like are they an ectomorph, an endomorph, or a mesomorph? Mesomorphs have lots of muscle mass. So even if they're overweight, underneath of that is big muscles. Big muscles need to be fed more protein. And people who are tiny don't need so much. So, and also I think it really does change in osteoporosis, for example, or not osteoporosis, but after menopause. I think it's probably better for women to move to a slightly lower protein diet, because when you eat large protein portions, it acidifies your blood. Your body then pulls calcium out of your bones to buffer your blood. If you blow through the buffer, limits, it'll pull calcium out of your blood, out of your bones, to kind of balance your blood out. And then once you use up those amino acids, the blood becomes too alkaline, and then you pee out the calcium. So too much protein after menopause is going to aggravate or potentially lead to osteoporosis in certain people. So I always recommend people have smaller portions, like 4-ounce portions of protein instead of like a 12-ounce steak or something like that. But often people's appetite declines a bit after menopause as well, and they're not wanting to eat as much.
Well, you did touch on this a little bit about your chosen form of zinc, and someone's asking, do you have any recommendations on zinc supplements that do not cause stomach issues, or when I'm having patients having trouble getting higher doses in for them? I assume you can spread it out throughout the day, but are there any strategies you want to give our providers on this?
Sure. So one of the strategies for zinc is that you give it in the evening. Don't give it in the morning. It will cause stomach pain in the morning in about 20% of patients. That's according to Dr. Walsh. And I have had that. I've had a few people have that for sure. I generally recommend taking it with dinner or taking it at bedtime. So I would say a lot of people don't have a tremendous success taking supplements with lunch, because they're often out and about or whatever. It just seems like the worst time of day for people to be successful taking supplements. But dinner time and bedtime are good. Bedtime for zinc has very good absorption rates, according to Dr. Walsh. Dinner time is generally fine, and people almost never experience nausea with that, or stomach pain with that. Now, you can definitely start out slow with the zinc, and it all depends on people's copper levels too. You want to start low. And I'm not sure if you guys can still hear me or not, so I'm going to just keep going.
We can hear you.
Oh, good. Thank you, because it froze on my end here.
Yeah, well, you froze for 2 seconds, but we're all good.
Okay,
We're all good. Keep going.
Okay, great.
I have a follow-up zinc question for kids that's coming.
Yeah, so sometimes I do liquid zinc for kids. There's some like zinc glycinate for kids. It's not my preferred method, but sometimes you just have to have it flavored and some way that they can take it. With kids, you're always negotiating how to give it to them. And you want to be able to titrate the dose really easily. So a liquid zinc makes dose titration fantastic. You can start in a low dose and gradually just add a few drops, or add half a teaspoon or a quarter of a teaspoon at a time, and gradually increase the dose over time, which you frequently need to do. And that's difficult to do with pills.
Yeah, someone's asking about a case study. So she's asking, how high do you feel comfortable going up on zinc? You said you could do liquid zinc, which is a good recommendation. I'm trying to figure out why giving zinc 50 milligrams caused zinc to go from 61 to 84 to 63. I'm considering malabsorption as the cause. Copper was 96 to 106 to 107. Latest ratio is 1.7. Ferritin stays low around 15 despite taking iron. 5-year-old with autism, no pyrroles, or pyrroles are normal.
Yeah. Sorry, what was the first zinc level?
Zinc level went from 61 to 84 to 63, and she's been giving 50 milligrams.
50 milligrams. Okay. And how big is the child? Well, we probably can't do too many
50
back and forth.
pounds, 5-year-old, 50 pounds.
So
Yeah.
that's a lot of zinc for a 50-pound kid.
Yeah, her question is, how high do you feel comfortable going? If she's trying to balance that zinc, it's like, well,
I would really, make sure they were really taking it. And I would maybe look at some other methods. So if I'm not sure with 50 milligrams, is it a 50 milligram pill? Kids can hide pills really easily. And parents don't necessarily know that that's happening, or they find them in, their plants or other places around the house, under the couch pillows. I might try switching to a liquid and dosing it more during, throughout the day, or putting it in something that they're drinking throughout the day. Yeah, and I would consider malabsorption, but you might need to look at the, digestive history of the kid, what else is going on, and stress levels, because stress impacts digestion a lot. But it doesn't totally make sense that it went up. Now, the other option is it didn't really go up, and that is an estimated zinc level when it went to 81. Zinc testing is notoriously tricky. And in my practice, because I live in a rural area and there are virtually nowhere to send people to get blood draws that, within 30 miles, I have done all my blood draws myself. And early in my practice, I had, kind of fluctuating levels and things happening with the zinc. And I was like, what's going on here? So I actually talked to Dr. Hansen at DHA, Ellen Hansen, about zinc, because I had one zinc blood sample clot really strangely and all kinds of weird stuff happening with it. So I got the scoop from her, which is when you're doing a zinc test for plasma zinc, which is what we want to do for this, not red blood cell zinc and not serum zinc. First of all, you have to use the blue top, metal-free tube, the royal blue top metal-free tube with EDTA in it. So it's got a lavender stripe on it. When you draw the zinc, when I do this, I draw the zinc, and before I am labeling the other tubes, I'm sticking that tube in the centrifuge and spinning it down right away. And then we're drawing off the plasma as soon as the centrifuge is finished, popping it in a transport tube. So we're separating everything out so that we're not getting extra zinc in the sample from either the tubes that are being used or from just letting it sit around for a while and have the red blood cells start kind of, relaxing and going, oh, we don't need this zinc, and we'll just ditch it into the plasma. And since I've been very strict in the protocol, which is what doctor, even is recommended on the sheet, but I was kind of new to it and didn't totally track everything at the beginning. I've had very consistent zinc results, meaning they're trustworthy. I never get what it looks like a really high zinc result that I think is lab error or sample error. So that is something to think about depending on where you're getting your zinc run, because labs aren't always paying close attention. It depends on what goes on. Somebody gets a phone call and the zinc sits there for a while, like the sample sits there before being spun or being siphoned off. So, but I might think of that. But in the same thing, if that is the case and it didn't really go up and it was just low anyway, and it was low at the end, you're still dealing with a malabsorption type scenario. Children are very tricky. So that's, I think it depends on what other skills that you have in your toolkit in terms of your practice. Is it, what other, are you like more of a psychiatrist dealing with kids? Or you're more of a holistic doctor dealing with all kinds of different issues with the kids and their mental health? What other tools do you have that you can address some of these issues? And sometimes it's like really digging into what's going on at home. Sometimes there's a lot of stress around meals that kids are embodying, I guess you'd say, or being impacted by. So I don't think there's like one quick answer. I would just try some different forms of zinc. I would not bother with zinc gluconate at all because it almost doesn't absorb. I would try picolinate, glycinate liquid, and then possibly orotate and possibly carnosine. Zinc carnosine or carnitine is used to help heal the stomach, and it's in a lot of the digestive formulas. So,
Thank
and
you
try
so much. That was a great answer. That was
long.
a great answer. What was the one to avoid? Zinc
Zinc
uh,
gluconate does not, it has
gluconate.
poor absorption, and that's the standard zinc that medical doctors frequently
Of
prescribe.
course it is.
Is
Of course it
available
is. It's the
at the
cheapest
store.
form. You can find it anywhere. So you guys, Dr. Seroya Crouch is not making it up about this zinc test tube stuff. This is not an exaggeration. I'm not making this up. I sat at LabCorp yesterday and I got my zinc plasma taken, and it was the blue cap bottle, and there was a little like maroon or red little stripy thing on it. And that's the exact test tube they have to use to measure zinc plasma. This is important because if you measure zinc serum, it's used in, it's the same tubes that other samples are being used in, and that can negatively or positively inflate the zinc level. And that can be a reason why, you can test zinc in a patient at the same time from the same draw, et cetera, and get 3 different zinc results back if you're using zinc serum. It's not always going to happen, but we've seen it. And that's why we use plasma zinc. And that's why when you order through DHA laboratory, we have that special account with LabCorp, so they're always taking our specimens and they are doing the protocol exactly how Dr. Seroya said. And that was a really such a cool thing for me to hear because I know what's going on and I saw it live yesterday, but it was so cool to have you go through it. I know we're at time, you guys. I'm going to ask maybe 2 more questions because I want to respect Dr. Crouch's time. Somebody's asking about Bartonella and stretch marks. What do you know about the stretch mark association with Bartonella? And then what do the stretch marks you describe to look like? Are they different when it's pyrroles?
The stretch marks with pyrroles are pretty standard. They're typically, just kind of white and some parallel to each other. Fresh ones can be a bit reddish temporarily. I'm not that familiar with stretch marks associated with Bartonella, so I can't really comment. I know that there are certain kinds of sort of stretch marks with like Cushing's disease and that are more reddish and really distinctive. But yeah, I'll have to look into that. I haven't really had any cases of Bartonella, so um, I'm not up on that.
That's okay. You guys, I'm sharing my screen. Please take that survey. The link is also in chat. And what I'm going to do is ask one more question that I saw just came in, and then I think we're gonna let Dr. Crouch go. Let me stop sharing my screen. Okay. Is there a blood-brain barrier issue that's common among pyrrole disorder or any other things you've presented today? And what's helpful in those cases when it comes to blood-brain barrier function?
Well, the answer is probably yes, that, blood-brain barrier is way more permeable than we have thought in the past. I think that one of the things that helps with brain function in general, and helps clean up, oxidative stress in the brain, which is created by pyrroles, is MT promoter. formula. However, and that's to help the body produce methionine. It has to be taken along with zinc in order for it to work. That's kind of a whole other topic area that's complex, and doesn't mean just go out and start giving MT promoter, but you really have to have resolved the pyrrole condition first. The one thing that will happen with pyrroles is you can give high dose or medium at least dose antioxidants, which are frequently prescribed and are recommended in the Walsh protocol. So that would be like 800 units of vitamin E, 2,000 units of vitamin A, 2,000 grams or 2,000 milligrams of vitamin C, and usually about 200 micrograms of selenium. So that's what's recommended because the oxidative stress created by the pyrroles, also same thing with copper. It does create this level of intense irritation in the system, and it's specific irritation to the nervous system. So you can quench some of that, especially when you're starting treatment and it's still quite high, with a good dose of broad spectrum antioxidants. So those definitely help. The methionine will help. It's an antioxidant for the brain. It also works in other parts of the body. It's a natural thing that exists in the body, but sometimes we're not producing enough of it. And that happens frequently if we've had an episode, a duration of zinc deficiency, because every molecule of methionine requires 7 molecules of zinc. And if you have a prolonged zinc deficiency, you're going to take the zinc and put it in other more critical locations in your body and use it different ways that are going to be life-saving, rather than making methionine with it. So you have to replete the zinc before you can even start methionine treatment. And then you have to give a little extra zinc to be able to to work with the methionine. But you can replenish methionine, metallothioneine, excuse me. Just everything I just said, metallothioneine. That is an enzyme that helps manage metals in the body, specifically zinc and copper and other things, actually. So, but it's a potent antioxidant in the body as well. And it does pass through the blood-brain barrier as far as I know.
Thanks, Dr. Seroya. You guys, I think I'm gonna let the doctor go. We have a couple more questions, but I definitely want to make sure we're not, going over anyone's time. Please, please, please take my survey. Let us know how Dr. Crouch did. Let us know how I did. Let us know what you want more of on DHA's webinar, what you want less of, and then
can I just say one more thing?
Yeah, please do.
Sorry, I was just looking at this question about the children and malabsorption.
Yeah.
What I have done with some children with malabsorption is I've used homeopathy. And I know that's sort of sideways to this, but I've used it in conjunction with zinc. And particularly a remedy that comes up commonly for children with malabsorption is silica, or like small children who aren't developing or tiny and look younger than their age, things like that, and are quite thin, often with very thin hair. Silica can often make a big difference, but it's because if it's the correct medicine for them, you have to do a proper case taking and everything. There are other remedies as well that are beneficial depending on the person, but I think it's really, children respond extremely well to homeopathy. So if it's not something you do, referring them to a homeopath for a remedy could really make all the difference and change their lives. So I would actually do that. And I think Crohn's probably not a huge issue in a really young child. They tend to develop a little bit later in childhood and adolescence, but I guess there are some children that might get it kind of early. But yeah, I would really look at homeopathy as a possible treatment plan.
Yes, thanks for sharing that. We just had from somebody, this doctor is amazing. Homeopathy is awesome. You guys, and I forgot, please read this book if you haven't already. You can see there's like a section of it that's like falling out of mine because it lives on my desk and I pick it up so often. This is Dr. William Walsh's first book. His second book is coming out very shortly. That's proprietary information, and we are so excited to support it. This is foundational in your practice. Dr. Walsh's advanced training, he has a mastering blood chemistry course he just finished up right now. They offer it twice a year, and they also do other offerings. So I dropped that link earlier in the live today. You have resources here. We are here for you. Let us know what you need when you need it. And Dr. Seroya Crouch, thank you so much for joining us on DHA Labs webinar series. We're honored to have you.
You're very welcome. It's been really enjoyable.